Recorded. So thank you for joining us today. Stephen, would you mind putting up the slides, please? Thank you. Okay. So today's meeting is to talk about the lifespan waiver proposal, and that's for sections 18, 20, 21, and 29. Next slide, please. So just to go over a couple of things for today's meeting to make sure that we understand that there'll be time at the end of this presentation to ask some questions. However, if some questions come to you during the presentation, please feel free to put them in the chat, and we will be reading those questions at the end of the presentation. There will be a recording of this presentation available along with the proposed rate models and the other supporting documentation. It's going to be posted at our Health Management Burns website that you see on this slide. And there's going to be a period of time for written comments, which can be sent to the ODES rate study at healthmanagement.com email you see posted. We can get that in the chat for you. Comments will be accepted through the 29th of April. All comments will be reviewed and summarized. Consolidated documents of comments and responses will be published, and rate models will be revised as appropriate. Next slide, please. So a rate determination process is what's outlined below. So this is defined in Title 22 MRS 3173-J, which is a standalone section of Maine law that was enacted in August of 2022, codifying the process and principles for the Maine Care rate system. So I'm not going to read the whole slide for you, but basically what it does is it enables that or mandates that we're going to set a schedule for regular rate review and adjustments, which could be updated differently depending on if it's benchmarked to Medicare and other payers or if we do a rate study. It ensures a review of relevant state and national data to inform rate amounts and payment models. It establishes a rate system subcommittee, the Maine Care Advisory Committee, which is also referred to as the MAC. Also the Technical Advisory Panel, which you'll hear people refer to as the TAP. And the TAP advises on related technical matters as appropriate and reviews an annual schedule of the rate determinations that will be considered for the following year. Next slide, please. So the purpose of today's presentation is we're going to go over some draft rate models for services provided for those sections mentioned earlier, 18, 20, 21, and 29, as well as the proposed lifespan waiver. Again, public comments will be considered before recommendations are finalized. We're going to, today's meeting is to ensure that all stakeholders understand the materials, data sources, calculations, recommendations, and so that you can review them and offer some comments on these models. Burns will respond to any technical questions that you may have or need addressed and to provide comments. We do encourage you to participate in today's comments at the end and to follow that up with some written comments to the Burns email address. Comments will be submitted in writing, and then that will allow for an aggregation of the review of everyone's feedback. Then there will be an implementation, and adopted recommendations will be contingent upon approval, federal approval and state rulemaking, and the state's budget process. So I am now going to turn this over to Betsy.
Thank you, Jessica, and good afternoon, everyone. I'm Betsy Hopkins, Associate Director here at the Office of Aging and Disability Services. And many of you know this on this call and have been actively working with us and even are working with us today in rolling out our new lifespan waiver. And that is really what is behind this rate study. As we've shared publicly in many different forums around the state over the last couple of years, after listening to gaps that we felt like we have in our current system, we really wanted to develop a waiver that would address some of those gaps with many of the new services that you're going to see listed here in this rate study, and many of you are working on right now as you're completing some, working with us on some readiness grants and getting technical assistance. We've really appreciated the engagement from many of you on this call as we've had that work come together for us. And we are really excited that we feel like this rate study really helps move us forward in our work, in that the rates will support the policy and the programming that we have put together in Lifespan. So we are thinking about Lifespan as a way to help people across their lifespan and adjust for them as they have needs that arise for them. We've talked a lot with families and others about the importance of the transition process from youth to adulthood, children's services to adult services. And by starting at age 14, which Lifespan will, we think that that will really help those individuals and families, especially. Lots of innovative services, as I've already mentioned, that we're really excited about. We saw them piloted in our innovation grants and now available in this waiver. We're focused a lot on more employment and community participation options in the waiver and promoting long-term sustainability, including responding to workforce challenges. So some other ways to provide services that don't heavily rely perhaps on workforce. We heard you early on in the process that it would be challenging to have rates and services that aren't similar across the waivers. So that's really what was behind us also including the other waivers that we have, 18, 20, 21, and 29, so that we have the same payment rates for those programs, those existing waivers, and then again for Lifespan, and that so that they're consistent across the programs. And with that, I'll turn it over to you, Paul.
Thank you, Betsy. Good afternoon, everybody. Paul Saucier, Director of the Office of Aging and Disability Services. It's great to see such a big crowd here this afternoon. Thank you for joining us. And thank you for your patience. We realize that this rate study has taken a while. And, you know, in addition to its comprehensiveness, 4 waivers plus Lifespan, what you'll see today in terms of an overview here is a lot of new rate models that get to the innovation, the program support, the workforce challenges that Betsy just referenced. And so it was not just a traditional rebasing of the old rates done in the old way. And you'll see a lot more, you'll see many details of that as Stephen Flowski goes through the presentation today. A couple of high-level points that I'd like to make, given relatively recent rate study and regular COLAs in the past several years. Most of the rates increase modestly, but that really impacts by service and by provider. And in some instances, you'll see that rates go down a bit because of changes in the staffing requirements. Given the workforce challenges, staff levels, generally speaking, are less prescriptive and/or they're reduced for certain key services, as long as that can be done safely within an individual service plan. And so in a number of areas, we are wanting to provide more flexibility to providers to manage their workforce and the way they deploy staff, as long as they can assure us that people will get their needs met and be safe within that structure. So for group homes, you will see us propose a true per diem rate. And the staffing thresholds, which many of you have struggled to meet, would go away under this system. So as long as you can staff appropriately and safely, then no need to staff at a particular level. we are proposing reduced staffing ratios for community support programs. I'm sure many of you know or have experienced that community support has not come back to the level it was at prior to COVID. That's a big problem and concern for all of our interest holders. And so looking at a different staffing model there makes sense. And then as part of our innovation work, we had a couple of you that in particular that did some innovation grant work around remote services. There are many more options today, both local and national, and we would we make that more accessible to you all again when appropriate. You'll see that the wage assumptions for DSPs exceeds the minimum requirement of 125% of minimum wage. And that just recognizes the labor market conditions that we're all working under. The staffing rate also includes comprehensive benefits package. And Stephen will talk more about that in a bit. And then we do propose to tier rates in a number of areas, and they are the big services today: agency home support, shared living, supported living, which would be a new service, and community support. And so based on a standardized nationally standardized and normed assessment, the SIS, which I think you're all familiar with, people would be categorized into one of 4 tiers, depending on what their needs are. And at the top of those tiers are people with significant medical or behavioral needs. This has been an ongoing concern that you've all expressed, particularly the behavioral. And so we think this will provide a much better approach to appropriately paying for those services. So with that, I will turn it over to Stephen to walk us through.
Great. Thanks, Paul, and good afternoon, everybody. I am Stephen Pawlowski. I'm with the Burns and Associates Division of Health Management Associates. We are the consultancy that was contracted by the Department of Health and Human Services to assist with this particular rate study. And I'm going to walk you through the balance of the presentation. We've divided it really into 3 primary areas. I want to spend just a couple of minutes providing a little bit of background, although Betsy and Paul did a good job, I think, of setting the table for me. Then we're going to spend some time walking through the approach, in other words, the methodology that we used in order to lead to the recommendations that we're offering today, which is then where I hope to spend the bulk of my time is walking through those recommendations. Just a couple of points in that regard. We're trying to focus today's conversation on the reimbursement aspect of the services that were included within our scope of work. There are an awful lot of moving pieces in this broader project to establish a new program like the Lifespan Waiver. Betsy and Paul touched upon a handful of those new services that don't exist in the existing programs, all of which are going to require new service definitions, the adoption of the support intensity scale to assess individuals' relative level of needs, and the like. So where appropriate, I'll talk about the nexus between those issues, things like service definitions and assessments and how that relates to provider reimbursement. But the presentation today really is around the reimbursement question, and I just don't have enough time to get into a lot of those other details. Additionally, when we get into the recommendations themselves, we're not going to be able to walk through every single rate model for every single service included within the scope of work. We're going to emphasize those that I think have some meaningful changes. In other cases, we're updating some existing rate models, or for some other new services, the methodology follows what I'm going to cover here at the top of my presentation. I want to encourage folks to review all of the materials that are going to be available on our website within the next 24 hours or so. In addition to this presentation, you'll have the rate model packets, you'll have the results of the provider survey that we conducted as part of this study, and the like. And then we will wrap up today with a brief overview of next steps. So with that, moving into the background, I just wanted to open with a couple of slides that show you what services were included within our scope of work. More or less, it's nearly everything that's covered by the existing 18, 20, 21, and 29 programs, as well as what is proposed for the lifespan program. The couple of exceptions are services that are reimbursed more on a cost basis, things like, say, assistive technology or home modifications. And then importantly, there are some other services reimbursed on a fee-for-service basis, but that are not covered in the scope of work. And those are professional and clinical services, things like occupational physical therapy. So there is a separate rate study taking place outside of this work. And the department's decision there was because those services span multiple systems. They're not just within these 4 waiver programs. It makes sense to look at those more holistically. So I won't be covering those services here this afternoon either. Otherwise, as this slide shows for the existing programs, and this slide shows for the lifespan waiver, just about everything else is part of the work that we have done. And you'll see a rate model for nearly every one of these services included in those rate model packets that I made reference to a moment ago. One thing that Paul touched on that we just wanted to reiterate is that for some services, we're building upon work that the Burns team has done previously. So I'll show you this in another couple of slides, but we've been working with DHHS for quite a few years now. I personally have been working with them for a long time, and many of these services we have previously taken a look at. And furthermore, we've built rate models for the rates that are in effect today, prior to, of course, the COLA adjustments that have been received in more recent years. So what we just wanted to illustrate on this slide is the investment that has been made by the state of Maine in a handful of core services within the existing programs. I won't read the details off to you, but this really demonstrates both the impact of the previous rate study that we conducted about 6 or 7 years ago, but that got implemented in 2020 and 2021, as well as the cost of living adjustments that have been implemented subsequent to that rate study. You'll see in the far right-hand column, some rather notable rate increases have been granted for a good chunk of services over the last 5 or so years. And so these final rates, what you'll see in the 2024 column, serve as the foundation for the work that we've been working on over the past 18 months or so. So I wanted to, I think, wrap up this section just briefly introducing my organization and myself. Burns & Associates is a health policy consultancy. Since our founding back in 2006, we have always focused on supporting state Medicaid agencies and their sister agencies, the developmental disability and behavioral health authorities. Since we were established 19 years ago, we've consulted in more than half the states, more than 30 states, and in fact, about half of the states' IDD systems. My introduction is a bit more of a mouthful than it used to be because we sold our company back in 2020 to Health Management Associates, so we're now operating as a division of HMA. As an organization, we do just about everything under the sun as it relates to Medicaid. We do have, and I personally have had a particular emphasis on services for people with intellectual and developmental disabilities. Within that space, we do everything from program design, so the front end of work, all the way to program evaluation, the back end of work, and just about everything in between. So that includes things like updating service definitions or provider qualifications, using assessments like the SIS to develop individualized budgets or to establish tiered rates, doing fiscal impact analysis of proposals I should say, policy designs and the like. We're most well known for the work that we do around provider rate setting, because if you're making recommendations about how much to pay somebody for something, that tends to draw a fair amount of interest. So we have done rate studies, much like the one we're talking about here in Maine, in quite a few states. As this map shows, I think we've done comprehensive IDD rate studies like this in about 14 states or so. And then we've done other IDD focused work in those that are shaded in the charcoal color. And that could be working on individualized budgets. It could be program evaluation, program design. As I said, we do a lot of different things within that within that IDD space. And then finally, this is a brief synopsis of our long-standing relationship with the department. So this shows you the work that we've done over the decade or so that we've been consulting to DHHS. I've actually personally been involved in some form or fashion on every one of these projects. The ones that are shaded in light blue are relevant to today's conversation. In the top left-hand corner, the first project that we worked on in Maine was actually looking at service rates for sections 21 and 29. Ultimately, the rates that we recommended at that point were not implemented. However, we then did some additional work a few years later that was expanded to include sections 18 and 20. And those recommendations have been adopted, and as I said a few slides back, serve as the foundation for today's payment rates for most, although not all services. So, as I said, I just wanted to get through the background quickly and wanted to spend more time talking about the methodology. So, because we've done a lot of work in Maine and because we've done a lot of work across the country, we have a fairly typical approach that we employ for every rate study related to home and community-based services, or HCBS. The term that we've developed over the years to describe our approach is incorporated here in the title of the slide, and that's an independent rate model approach or independent rate setting approach. And all that we're really trying to convey here is that we're not dependent on any single source of information. Instead, we're trying to gather data from a variety of different sources so that we build rates that reflect the reasonable costs that providers incur to deliver services consistent with the state's requirements and individual service or treatment plans. Fundamentally, that's our mission statement as it relates to HCBS rate setting is the state defines the service, but once they do so, we want to make sure that we're building rates that reflect those expectations and those requirements. In order to answer the question, how much does it cost to deliver services, we are going to look for information from a variety of sources. And that includes always starting with the underlying requirements and service definitions. It includes provider and stakeholder input through a variety of mechanisms, including today's presentation and the public comment process that we are kicking off today. Published sources of information like the Bureau of Labor Statistics, which I'm going to come back to. And then on an as necessary basis, sometimes we also conduct special studies to make sure that we're building rates that really reflect the unique circumstances that each state has. We'll spend a lot of time talking about the rate models that we produce as a result of these rate studies. And what you're going to see in a couple of slides is an example of one of those models. You will see that we have outlined the specific assumptions that we make in order to arrive at a bottom line. And we think that's really important because rather than arguing about whether or not a rate ought to be $40 or $41 per hour, we'll be able to have an informed conversation with you about whether or not our rate model assumptions are appropriate. Is the wage that we've built in for a direct support professional sufficient to attract a high quality workforce? Have we adequately accounted for the cost of providing them benefits? Have we put in enough funding for agency overhead expenses, et cetera, et cetera? And you'll see that we're very detailed in our work, and we're hoping that when you submit your feedback to us through this comment process, that you'll be equally detailed. It's one thing to say we don't like the rates, but what we're really looking for is we believe that this assumption is solid or this assumption needs a little bit of work and should be reconsidered. It's important for me to highlight that the assumptions that we include in the rate models are not meant to be prescriptive. We're not telling providers how to do their jobs. For example, we're not telling you you have to pay your staff exactly what's been built into the rate. Instead, we have to make those assumptions to get to a bottom line. And you, as an employer, as a provider, have to make decisions that allow you to operate within your revenues and provide services consistent with the state's requirements. The second half of this slide makes the point that a single service may have multiple rates, and that can be for a variety of reasons. Rates might vary based upon level of need, and Paul already gave you that punchline earlier in his remarks that we would propose a tier rates for a variety of services so that the provider is paid more for supporting people with more intensive needs than folks with comparatively fewer needs. Rates can vary based upon the setting. You'll see that in what we're recommending for community supports or day programs. Sometimes, although not in this particular project, rates will vary based upon where the services are delivered. And then rates might also vary based upon who's delivering the service. An example of that is for the behavioral consultation rate that you'll see later in this presentation. We have different rates for LCSWs than for BCBAs and psychologists. So when I talk about these rate models, you're going to see 5 components in nearly every rate that we build. 3 of those, which are highlighted in blue on this slide, relate to the direct support worker. That is their wage, how much are they paid, their benefits, including payroll taxes, health insurance, and discretionary benefits, and what we refer to as productivity, or the time that they have on non-billable, the time they spend, I should say, on non-billable activities. The 2 remaining aspects of all of our HCBS rate models are for agency overhead expenses. We divide that between program support and administration. On the right-hand side of the slide, we show that there might be other factors that go into rates as well. For example, if we're talking about a shared service, we're going to make assumptions related to things like staffing ratios or staffing levels. If it's a service that is delivered in a home or a community, we'll build in transportation-related expenses. If it's a site-based or clinic-based service, we'll build in the cost of the bricks and mortar to operate that building and the like. So not an exhaustive list, but we just wanted to tell you outside of the 5 core elements, there are other aspects that vary on a service-by-service basis when we're building these rate models. So to provide more concrete understanding of what we mean when we're talking about a rate model, I've displayed that here on this slide. So this is actually our proposed rate for a home support quarter hour. I'm not going to walk through it line by line, but what I want to draw your attention to is the very bottom row, and that is what the final rate is. And what we're recommending is a rate of $12.55 per quarter hour, which of course is helpful information for providers watching this webinar. But as I said, rather than just giving you that bottom line, what the total rate is, you can see exactly how much we've assumed for all of those 5 key elements and then anything else that is relevant to this service. So we talked about direct support is where we always start for home and community-based services. That is going to be the single largest expense that providers incur. So we spend a lot of time thinking about what's the appropriate payroll expense. And we'll talk in a little bit about where it is that $19.76 assumption came from. We then make adjustments to the cost to account for productivity. And as I said, that's our measure of how much time folks spend on billable activities in relation to their total work hours. So as demonstrated on this example, if someone works 40 hours per week, our question is how many of those hours can be billed? Because we know that staff have other responsibilities. For a service like home support, they're driving to individuals' homes, maybe from person 1 to person 2 or between the office and the individuals they serve. They might be attending care plan meetings. They might be doing documentation outside of service delivery. Hopefully they have some paid time off. Hopefully they spend some time in training each year. And so after we account for those activities, we're assuming that in a 40-hour work week, they're only able to bill for 31 hours. We use that ratio to increase the rate that would otherwise be paid, because all of those expenses, paid time off, travel time, training time, non-billable record keeping, that's a cost of doing business, right? Employers are incurring that expense, but they cannot bill for that time directly. So we need to make sure that we're building assumptions in that allow those costs to be recouped over the hours that they are able to bill for. So out of that 40-hour work week, we're assuming that they're billing for a little bit fewer than 31 hours. The cost of that other 9 hours gets layered into the rate. And then, as I said, we have a couple of assumptions related to agency overhead. Program support are those functions that are associated specifically with a given service or line of business. So that includes first line supervision, quality assurance, curriculum development or program design, functions that you're doing because of the services that you're providing. Whereas administration occur at a higher level, the organizational level, and those will exist regardless of the service that you're providing. So executive leadership, a business finance office, human resources, etc. We think it's important to separately identify those expenses because they're serving different roles, they're fulfilling different needs. And if we just lumped everything into an overhead or administrative cost assumption, I think we'd be overstating how much is devoted to quote unquote administration and not appropriately reflecting how much is necessary to build the programmatic infrastructure necessary to deliver high quality services. And then finally, as I said, other assumptions vary on a service by service basis. Because this is a home and community-based service, we have the cost of mileage built in, and then we use the IRS's mileage rate to estimate the vehicle-related expenses. Again, really the point of showing you this detailed rate model is to reiterate the point that I made a moment ago, which is we show you our work effectively, how we got to that $12.55 recommendation. And as you're evaluating the goodness or badness of our work, we're hopeful that you will evaluate specifically the assumptions that we've made. And if you think something is not appropriate, something isn't going to allow you to deliver the high quality services that the state expects, you'll point that out and offer alternative suggestions. I spent just a moment talking about the benefits that we see in developing rates in this fashion. First and foremost, we hope that you will agree that we're going to be transparent in our process. We're not going to have agreements on everything that we've put forward, and ultimately I don't think there'll be agreements on all the final recommendations, but we're showing you exactly how it is we got there so that when you offer your feedback to us, you'll know what those moving pieces are. Similarly, by outlining specific assumptions, targeted adjustments can be made, and that can be made either to further policy goals or simply to keep the rate models up to date. For the former, implementing policy goals, let's say, for example, you want to increase, or the department, I should say, wants to increase the level of training for a direct support professional. You can go into our rate model and replace the number of training hours that we've built in with a higher number of training hours. Or if the department wants to move towards lower staffing ratios, you can replace the staffing ratio that we've built in with that lower staffing ratio. It doesn't require going through a time-consuming and costly rate study process to make those sorts of targeted adjustments. Similarly, although this is not the way it has been operationalized in Maine to this point, you can make targeted adjustments to the rates to account for rising expenses. So I mentioned a moment ago the use of the IRS rate to fund a vehicle-related costs. That gets published every December. So as that new figure is published, the department could go into the model and replace 70 cents with whatever next year's mileage rate is. I noted, of course, the cost of living adjustments that have been granted in recent years have been to the bottom line as opposed to targeted adjustments to the rate models. But by outlining our specific assumptions, folks know over time whether or not the assumptions continue to reflect current expenses or not. This slide illustrates our rate setting process. As I said, we have done dozens of rate studies like this over 14 or 15 states now. And because of that, we do have a typical approach that we employ. We divide our work into 3 phases, which are color-coded on this slide. The first phase is doing the background research work. The second phase is doing data collection. That's both primary data collection through things like a provider survey and secondary data collection that we use published sources of information for. Those work streams come back together for the third phase, which is actually building out our recommendations, putting forward our draft rate models, getting comments on those models, and then finalizing our recommendations to our client. I have a slide or two that addresses each one of these specific tasks. So in phase one, it really is important for us to spend a lot of time familiarizing ourselves with the system in which we are working, because the needs of Maine are not the same as the needs of California or Hawaii or Alabama or Georgia or any other state that we've done similar work in. The example that I like to use is a day habilitation or day program or a community supports service. Every state's IDD program covers a day program or day habilitation service, but the details can vary pretty substantially from one state to the other. In Maine, for example, the historic practice has been a 1-to-3 staffing ratio, whereas in other states that we work, there are ratios as high as 1-to-10. Of course, from a provider's point of view, it's going to be a lot more costly to deliver services at 1-to-3 than it is 1-to-10. So we can't simply take a rate model that we built in another state at 1-to-10 and drop that into Maine, because it's not going to cover the expenses of operating at, say, 1-to-3. Similarly, how transportation costs are covered varies. Whether or not there's a meal or snack required as part of that day program varies, et cetera. So it's not enough for us to have done lots of rate setting for day habilitation programs before. We need to make sure that we understand what Maine is looking for in their day program or their community support service. So we do that by reviewing waivers, in this case, the Maine Care Benefits Manual, similar policies and regulations, any previous rate studies or reports that have been done, and the like. We always supplement that with information from key stakeholders, both internal and external. As we go through those policies and regulations and statutes, we write a lot of notes, pages and pages of notes. And then we subject our clients to a day-long or multi-day conversation to make sure that we understand what all of those service requirements are, filling in any gaps that we find when we're doing our evaluation. And then similarly, we meet with an external group of stakeholders, a provider advisory group, to get that on the ground firsthand knowledge. And there is no substitute for the knowledge of the folks that are doing this day in, day out. So we bring that group together to ask what's working well, what's not working well, what do you think ought to be our priorities for this particular project. So we have those kickoff meetings early in our engagement to really set the tone for the work that we're going to be doing. As I said, our next phase of work is data collection. We do a provider survey. For those of you listening to this call who completed the survey, thank you. I know it's a lot of work. It takes a lot of effort and time, but it really is a key consideration, not the only consideration, but a key consideration in the development of our recommendations. Ultimately, we received surveys from 43 of 159 providers that delivered services in fiscal 23. But they represented about 46%, so nearly half of the services delivered, which is a pretty solid response rate. So again, thank you for all of you providers who took the time to complete that survey. And then, particularly for home and community-based services for the IDD field, we spend a lot of time looking beyond just the provider survey, current costs and operational considerations, because we know that providers' expenses are a function as much as anything else as the rates that are being paid. And that is particularly true for HCBS for the IDD population, because Medicaid is really the only game in town across the country. Medicare pays for very few of these services. Commercial insurance pays for very few of these services. There's not a lot of ability for people to private pay. So it's different than when my company does hospital rate setting, for example, because hospitals have a diverse mix of payers, commercial insurance, Medicare, Veterans Administration, et cetera. Whereas in the IDD space, the only payer is typically Medicaid. And so if all we're looking at are current expenses, really what we're validating is the existing rates that are being paid, because providers have to make those two ends meet, right? They have to live within their revenues. And so it's really important for these types of rate studies that we look beyond provider cost data. We certainly look at it, but we look beyond as well. And so that includes things like that BLS data that I will go into more detail in. It includes benchmarking, payment rates, or programmatic requirements where appropriate. And then for services with tiered rates, making sure that we're thinking through what the appropriate level and intensity of services would look like across those varying levels of need. What's the difference in supports for someone who's assigned to tier 1 versus someone who's assigned to tier 4? As I've said, and as you've seen, we then pull that information together to develop our draft rate models. At this stage, we kick off our public comment process. We'll close with more commentary about this, and I think Jessica actually mentioned some of this at the top, but after you've had a couple of weeks to review what it is we've put forward, we're looking for your responses in writing. And we're going to develop a document that summarizes all the feedback that we received and offers the department's response. If a change is made, we'll explain the change. If we don't make a change, we'll provide our rationale for not having done so. And that takes us then to finalizing and publishing those final rates. If implementation occurs, then we're also there to provide support on an as-needed basis. So doing things like fiscal modeling, providing briefings or trainings. If it needs to be phased in over a period of time, we can help design what that phase-in plan looks like. But just like the draft rate models, this will be done transparently. We'll show you the public comments. We'll show you our final recommendations. And of course, at that point, as was mentioned at the top, implementation will be contingent upon federal approval and state rules and budgets. So I know that was a good amount of background, but I wanted to make sure folks understood the methodology that went into the work that we have done. Now we'll spend the balance of my time walking through the recommendations themselves. And I've really divided the recommendations into two groups. The first set of slides cover recommendations that cut across services. And then the second set of slides are some of the service-specific highlights that we wanted to cover with all of you this afternoon. So I'm going to need to take a few minutes to walk through how it is we develop our wage assumptions. And I think that time is warranted because, as I said, that's going to be providers' single largest expense. And of course, the quality of the direct support professional is also going to be a direct corollary to the quality of the services that are being provided. So it's worth our while to make sure that we've built in a sufficient wage and benefits package that allows providers to recruit and retain a high quality workforce. So where does that information come from? The short answer is that it comes from the main specific data published by the Bureau of Labor Statistics, which is a federal office within the United States Department of Labor. It is, as I said, though, main specific information. Sometimes folks get confused and ask us whether or not we're using national averages. The answer is absolutely not. We're using main specific figures in order to develop these recommendations. The reason that we like BLS data is outlined on this slide. I'm not going to read all of those bullet points to you, but it really is the gold standard in terms of identifying current wages across a wide variety of occupations, including occupations that are relevant to what's included within our scope of work. Ultimately, not only do they cover a lot of services, think of that top to bottom, they provide a lot of different, I should say, a lot of occupations. They also provide a lot of different wage estimates. Think about that as left to right. So they publish what kind of the low end wages are, the 10th percentile, the 25th percentile, the average, which would be the median or 50th percentile, and then the high end wages within an occupation, the 75th and 90th percentiles. When we're doing rate setting, ordinarily what we rely upon is the median wage. That's the wage at which half the folks in an occupation earn less and half the folks in that occupation earn more. We think, in other words, that's a reasonable approximation of the marketplace for folks that are doing similar work. That has also been our practice in our previous engagements with MaineCare. There have been a handful of exceptions, but by and large, when you look at how it is we build wage assumptions, it is based upon median wages taken from the BLS data. The BLS data gets published once a year, and it's published now 11 months behind, so it's always a little bit out of date. The most recent information, and part of the reason that we delayed until this point, is they published now in early April. So we got our most recent data delivery on April 1st or 2nd, I want to say. And it reflects the previous May. So published April of 25 reflects May of 24. But we're not building rates for last year, we're building rates for next year. And so what we've done is we've inflated the BLS data to July of 25. In other words, the midpoint of this year. And the reason that we did that is because the presumption would be that COLAs in 26 and beyond would be applied to the rates that we're recommending today. So the rates that we're recommending today reflect the current year, and then the COLA would do its job for future years until such time as there's another rate study. In terms of how we inflated those wages, we're using information from a different federal office in a different federal department, the Bureau of Economic Analysis within the Department of Commerce. Again, Maine specific data for the average growth in net earnings over the past 10 years. It's been pretty healthy in Maine. It's averaged about 5.2%. And so if we compound that to go from 14 months, May of 24 to July of 25, that calls for inflation of about 6.1%. So all of the BLS data has been updated by 6.1%. After we did our work, and I'll get into this in the next couple of slides, we also verified that any recommendation that we put forward for wages is compliant with that 125% requirement, and they are. So minimum wage today is $14.65, 125% would be $18.32. All of our wage assumptions exceed that $18.32 floor. So this is a topic that I know is popular with some folks on this phone call and a number of providers across the country. And that is, although the BLS publishes data for more than 800 occupations, there is not a specific occupation called direct support professional. Now, I want to be quick to note that DSPs are absolutely included as part of the BLS survey and part of the published BLS data. However, what the BLS does is group DSPs with other paraprofessional direct care workers into a broader occupation called home health and personal care aides. So DSPs are part of the survey, they're part of the published data, but they're lumped in with other staff. And I know there's a lot of interest amongst a lot of providers and advocates to pull DSPs out. That was not done, has not yet been done by the BLS. So what does that mean for us? We could use the home health and personal care aide occupation as our benchmark because that is where DSPs are assigned. However, as a consultancy, we've always believed that that undervalues the importance of the work that DSPs do and the variety of responsibilities that they have. And so instead, we build a composite of multiple occupations that we think represent those varied responsibilities. And you can see what we've done for residential DSPs on the bottom part of this slide. We always start with the home health and personal care aide because that is where DSPs are assigned. But then we also think about how it is they're helping people access the community and other services and support. So that means we bring in things like social and human service assistants and recreation workers. We also recognize that oftentimes they're helping to manage behaviors, and so we build in the psychiatric aid occupation as well. And so you can see that we've come up with a weighted average of those 4 occupations. Now, I will admit there is as much art as there is science into this, but we think this does a reasonable job of accounting for those varied responsibilities. A lot of time spent on home health and personal care related functions, but also helping people access the community, helping people with challenging behaviors or medical conditions and the like. And so based upon those assumptions, you'll see that we've arrived at a wage of $19.76 per hour for our residential DSPs. In terms of how that compares to provider survey results, you'll see a handful of core services. What we wanted to gather were the surveys where we had the greatest number of responses. We didn't want to provide comparisons where we had fewer than 10 responses for a given service. And as you can see, if you just focus on the right-hand part of this table, the assumptions that we built in do exceed what providers report they are paying their staff today by varying levels. Somewhat modest for in-home and group home services, a little bit larger for day program type services, and then a significant premium for employment supports. Okay, so we've covered the wage assumptions for direct care workers. Now I wanted to go through the payroll taxes and fringe benefit assumptions. I'll start with the payroll taxes. That's, in the scheme of things, straightforward. We include FICA, Social Security and Medicare payroll taxes, state and federal unemployment insurance, paid family medical leave, and workers' compensation. Most of those are statutory. As it relates to state unemployment insurance, we use the rating for new employers. For workers' comp, we're relying upon some published information for the worker classification within the state of Maine. Outside of those payroll taxes, we build in 25 days per year of paid time off, so the combination of holiday, vacation, and sick leave. We also build in the cost of health insurance. And one of the things that we've done differently over the past 5 years or so is to build in a mix of plan types. If you look at the work that we did for 18 and 20 and 21 and 29, 6 or 7 years ago, I think that was just for an employee-only plan. In our rate models now, we're recognizing that in order to be competitive, providers have had to offer more choice for health insurance. Now we've come up with a model that mixes employee-only plans, employee plus one plans, and family plans. In terms of how we come up with the overall participation rates, as well as the mix of plan types and the cost to the employer, we are again relying on Maine-specific data from a federal department. This is the federal HHS and their medical expenditure panel survey. What the rate model includes is a little bit more than $700 per month for all employees. That includes non-participating employees. If you take out the non-participating employees, those who have health insurance through their spouse or Medicare or the Veterans Administration or are a young invincible and just choose not to participate in their employer offering, the cost per participating employee is closer to $1,000 per month. So again, that's an area where we sometimes see confusion. Folks will say my average premium is more than $700 per month. I don't doubt that. But you also have, we're assuming, a portion of your workforce that your cost is zero because they've chosen not to participate in that health insurance plan. The specific details are included in Appendix B of the rate model packet. And then finally, we include $200 per month for other benefits that are offered at the employer's discretion. So that would include things like vision and dental insurance, a retirement plan, tuition assistance, an employee assistance program, and the like. We found that those other benefits are offered typically by a minority of providers. And so we didn't want to come up with all of the possible offerings that an employer might make available to their staff, but instead included this catch-all for anything else that is offered at the employer's discretion. Another technical point, and I know I have a lot of technical points in this presentation, is how we convert those assumptions into a benefits rate. So most of us who work with budgets are accustomed to thinking about benefits as a percentage of wages. And so that's the way the rate model presents them. I didn't highlight it when I was going through the home support example earlier in the presentation, but I think we have like 38% built in for benefits. Two key points. The first is the benefit package is the same across all direct care workers. But point number two, because we are comparing that to their wage, the value of that benefit package varies based upon the wage of the direct care workers. Let me make that easier to follow. I said before that we built in $700 per employee per month for health insurance, so a little bit better than $8,000 per year. If I'm making $20 per hour, that $8,000 is a pretty significant portion of my total compensation. If, however, I'm making $40 per hour, that same $8,000, the same benefit package, is a smaller portion of my total compensation. In other words, it's a lower percentage of my wage. So again, just drawing on my experience and where we sometimes run into confusion, people will say, why do you have more benefits built in for the DSP than you have for the BCBA? The answer is we don't. It's the same benefits package for everybody, but when we compare that to their wages, there is an inverse relationship, which is what the chart on this slide shows you. As the wage increases, the benefit rate goes down. The benefit cost goes up, but the benefit rate goes down as a comparison to the wage. So this slide is not important other than to make sure folks understand why that benefit rate varies. What's important is the previous slide and what we've built into the benefit package, how much we've built in for health insurance, how much we've built in for paid time off, et cetera. This is just how that gets calculated as a percentage of wages. Next topic, again, is still the direct care worker. As part of my top 5 items within all rate models is productivity. I've described this a couple of times already, but the idea here is how do we account for the non-billable responsibilities that direct care workers have? In the example that I showed earlier, we had a 40-hour work week and folks are doing 31 billable hours per week. And so how does that then translate into the rate model assumptions? A simpler example is shown here on this slide. Let's assume that an employer's cost is $20 per hour to employ their direct care worker. That's their wages and their benefits. So it truly costs them $800 per week, right? 20 hours, $20 per hour, 40 hours per week, $800 in total. But if that employer can only bill for 32 hours per week, we need to calculate a productivity adjustment. And we do that by dividing worked hours by billable hours. So in other words, 40 divided by 32 is 1.25. And we use that to inflate the billable rate. The true cost is $20 per hour worked, but the cost per hour billed needs to be inflated by applying that productivity adjustment. So multiplying the $20 by 1.25 gives you $25 per service hour or per billable hour. So again, this is just the math behind it. On the next slide, we talk about some of the specific assumptions. The first standard assumption is for paid time off. As I mentioned, we have 25 days per year built in. That equates to 200 hours per year. And we treat that as a productivity assumption because it really is a reduction to hours that you can bill for. If someone is on vacation for a week, you're still paying them for 40 hours, but you're not billing any of that time. So out of the course of their overall year, you're rather than billing for, say, 2,080 hours, you're billing for 2,040 hours before you account for, of course, all the other productivity adjustments. In general, rate models include 50 hours per year for training, which is about an hour per week. That's meant to represent an average of folks in their first year of employment versus those folks who have been on the job for multiple years. There's more training required in our first year on the job than after our first year. Additionally, and I'll come back to this tier 4 issue in a moment, but we have more training built in for some services where we think more training would be appropriate. And that includes supporting people with more significant needs, as Paul mentioned in that highlight slide. And then most services include an hour per week for supervision and employer time. So that's things like attending a staff meeting, getting counseling from your supervisor once a month, filling out your timesheet, etc. Other than those standardized assumptions, there are other assumptions that vary more on a service by service basis. Things like traveling between encounters, record keeping, program setup and cleanup, and the like. All of the assumptions for productivity are in each of the individual rate models, just like when you saw the home support rate model. Furthermore, they're also outlined in Appendix C of the rate model packet. So there's a lot of detail about productivity within the rate model packets that will be online within the next day or so. Wrapping up my final 5 on core HCBS rate model assumptions, we'll talk about overhead expenses. I already defined admin and program support, so I won't do it again. But what I'll note is that program support is funded at $30 per day. And we do that rather than a percentage to account for the higher costs for shared supports like day programs, for example. and also to not overfund professional services at the expense of paraprofessional services. If everything is a percentage of total, you end up putting a lot more money into, say, the BCBA rate than into the DSP rate. So the $30 per day smooths out the individual versus group services and the paraprofessional versus professional services. For admin, we do fund that at 15% of the total rate. So there's two components, $30 per day for program support, 15% for administration. Overall, in combination, those two assumptions are consistent with what was reported in the provider survey, which was about 26% of total expenses going to the combination of program support and administration. So I do need to spend a minute or two talking about tiered rates, which Paul introduced already. As I said, I'm not going to be able to do a deep dive into how the tiers were established. There are other materials available. I believe other materials will be also shared at a future date when the overall waiver application for lifespan is ready. But at a high level, we do propose a tier rates for sections 21 and 29, as well as the lifespan program, to account for intensive supports for individuals with more significant needs. This is a familiar concept because these programs already have a medical add-on rate. So this is a different approach to identifying and ultimately funding those additional needs, but it is not something that is foreign, I don't think, to the existing provider community. In terms of to whom it applies, it will apply to those individuals with the most significant general support needs. So think about that as ADLs, or activities of daily living, the most significant medical support needs, the most significant behavioral support needs, as well as those with specified challenges in communication. So there's still work to be done in writing the rules around that, but the idea here is, for example, if someone needs to be addressed in a non-English language, including American Sign Language, this rate would be available there as well. In terms of what services it applies to, it's primarily targeted towards services that are shared or delivered on a 24-hour basis. So think about that as group homes, shared living, the new community supported living, as well as the community support or day program services. Additionally, there are certain outcome-based or milestone-based employment rates that are tiered as well. Finally, there's a number of rates that are one-to-one, but include what we call a tier 4 rate to provide higher payments for supporting those individuals with more significant needs. And the rationale there is that it's expected that the staff who are delivering those services are going to need a greater skill set to work with people with really challenging behavioral or medical needs, or who don't speak English. So the tier 4 rates for those services are meant to pay a premium to the direct care worker who's delivering supports to those participants. We did that for consistency, but when you look at it, there is no tier 1, tier 2, or tier 3 for these one-to-one services. It's just the standard rate and the tier 4 rate. Tier 4 is how we're indicating the highest level of needs across all services. My 1 or 2 slides about the SIS itself. Again, this is going to be skipping across the surface, but the intent for tiering rates would be to use the SIS, and that will be used to assess general support needs, ADLs, medical, and behavioral support needs. Paul already mentioned that this is a standardized assessment tool. It was developed more than 20 years ago now by the American Association on Intellectual and Developmental Disabilities. And in 2023, they released a second edition, which makes some minor changes to the assessment itself, but more importantly, changes how it is scored, because the initial launch in 2004 was based upon, I think, 1,400 assessments, and now AIDD has access to hundreds of thousands of assessments because this tool is used by more states than any other single tool for the purposes of identifying needs within the IDD community. So a number of states, more than 20, have adopted it, and there have been hundreds of thousands of assessments conducted now over the past 20-some years. Additionally, ODES, following best practices, has adopted some supplemental questions to do a deeper dive into medical and behavioral needs and make sure that folks that have significant needs in those areas are identified. So there are a handful of supplemental questions that have been added in Maine to the SIS. A different consulting firm, the Human Services Research Institute, was contracted to develop the support level framework. Again, this is the only slide I'm going to cover that goes into the details, but I will say that HSRI did a lot of work in order to get to where we're at today. They analyzed results of a sample of assessments from Maine consumers. They compared that to the national data set that they also have access to, given their partnership with AAIDD. And then there was a case file review that was conducted to evaluate the appropriateness of the level to which an individual be assigned and what their individual budget ultimately would provide them for. So a lot of effort went into building this, a lot of statistical analysis, and then complementing that with some qualitative analysis through that case file review. Ultimately, HSRI has proposed a 6-level framework. You can see the criteria outlined in this slide in the interest of transparency. What's relevant to me and our conversation today is actually the far right-hand column. So we have 6 levels, but 4 rate tiers. And the reason for that is if you look at the bottom 3 rows, we have people with high support needs, but for different reasons. General support needs, medical support needs, and behavioral support needs. These are all the highest needs populations, although they have different types of needs. We're assuming that the intensity of those supports are comparable. And so for the purposes of our rate study, we've grouped those 4 categories together, which is the way nearly every state translates levels of need into rate tiers or rate categories. One final overarching point I wanted to make before I get into some of the service-specific recommendations revolves around remote supports. And this is a language issue that I sometimes get tripped up on, but what we're referring to here is not a specific service called remote monitoring, which typically involves technology that helps a remote worker provide oversight and supervision to an individual. What we're talking about here are other services that are delivered through remote means. So you can think about that as home support quarter hour being delivered remotely. So not general unspecified supervision, but actually working with the individual directly, but through technology. We wanted to both recognize that this can be a way to extend to the workforce and also perhaps encourage choice and innovation in the design of services. At the same time, we wanted to recognize that delivering services through remote technology typically results in greater efficiency. In other words, you're not doing the drive time to do the home support quarter hour because you're calling them from the office. And so we have fewer productivity adjustments built in, and we take out the transportation related expenses. So the rates for remote support are a little bit less than the rates that are delivered in the home and community. You'll see the listing of services that have a remote support rate attached to it here at the bottom part of the slide. Again, I won't read them to you. Most of these services are associated with the new lifespan waiver, but certainly home support quarter hour and individual work support are part of the existing programs, I should say. So doing my best to hustle through the material, I'm going to cover now some of the service-specific recommendations. Again, I don't have time to walk through every rate model as much as you might enjoy listening to me talk for 6 or 7 hours. That's not what's been scheduled for today. So I'm going to open with a couple of tables that show you when there aren't a lot of moving pieces or changes to billing conventions, what the rates are. And then from there, we'll spend more time getting into some of the more substantive recommendations where there have been recommendations to change billing procedures and things like staffing ratios, which Paul made reference to earlier. So, as I said, the first handful of slides are just a crosswalk of existing rates to proposed rates for existing services. And then we have a table of proposed rates for a handful of lifespan services as well. I'm not going to read these to you. The detail behind all these rate models are also included in the rate model packet, which, as I've said, will be posted online. But in terms of how to read this, you'll see the name of the service in the first column, the unit of billing. So for home support quarter hour, that's billed in 15-minute increments, as its name would imply. The current rate is $10.94. The proposed rate is $12.55. So that's an increase of 15%. For real estate purposes, I don't have included on here the remote rate. I also don't have the rates for delivering services in small groups, which would be in addition to this service for, say, a sibling group. So we also have 1 to 2 and 1 to 3 rates built. I did want to make sure that we're highlighting what the tier 4 rates when those apply. So again, this is new, but the existing rate of $10.94 would be increased to $13.50 for those folks with high general support needs, high medical, high behavioral needs, or with communication challenges. Also on this slide, we cover the updates to the rate models for residential services through sections 18 and 20. We haven't made any changes to the assumed staffing, and we continue to assume a 350-day billing year, which I promise I will come back to here in a few more slides. Another handful of slides, which are updates to existing rate models. So we built rate models for these services back in that 2018-2019 rate study. What we've done is gone through and made adjustments where appropriate, certainly including more updated cost data, but making other targeted adjustments where appropriate. Then we have a set of services that already exist in sections 18, 20, 21, and or 29, but that we did not previously build rate models for. So now we have built rate models for these services. We followed our same methodology, right? So although these are new models, they follow the same approach that I've covered at some length this afternoon already, in terms of how we build out those 5 key components. We build in other components on a service-by-service basis, accounting for wages, benefits, productivity, overhead, and the like. So again, you'll be able to see these models incorporated in the rate model packets for existing services. Then we've put forward in a separate rate model packet, the services to be covered under the proposed lifespan program. So on this slide, of course, there will not be a current rate as a point of comparison. Couple things that I wanted to highlight here. Again, for the home-based independent living skills, there will be limits on that service based upon the needs of an individual and how long it is anticipated to take in order to train them on the skill on which they're being trained. There's also a transportation service included in the lifespan program called community non-medical transportation. What we propose is that would be billed per mile for the miles that an individual is transported. This is an agency rate. We don't go into it in detail in this presentation, but that would also be available through self-direction. And so individuals will be able to pay on other mechanisms if they're, say, perhaps buying a bus pass or using Uber or Lyft or something along those lines. So there'll be flexibility with how folks can use transportation funding through a self-directed model. Again, I don't have separate slides for all of these services, but you'll notice some other more outcome-based or milestone-based payments for a handful of employment supports. The first is job and career development planning. So this service culminates with the completion of a plan. We have tiered this rate because we assume it will take more time to complete that plan when people have more significant needs. So you'll see the rates published here. In the parenthetical comments there on the right, you'll see how many hours we've assumed it takes in order to complete the plan at those various tiers. But the idea is we want to make sure that there is access to this service across individuals of all tiers. And if we only had a single rate, the concern was that providers would have less incentive to work with individuals who will require more effort to complete that process. Similarly, there's a service for supported employment exploration that would culminate in a report, and that would be billed after that report has been submitted and approved. I just want to note that I am not doing justice to the continuum of employment supports that will be available through the lifespan waiver. One of the things that Betsy mentioned behind the impetus for the lifespan program is facilitating and increasing individuals' access to employment within the community. So the ODES team has gone through a lot of effort to build a continuum of employment supports to help people at each stage of their employment journey. That's outside of the task that I have in front of me today, which is talking to you about provider reimbursement. But I thought I would be doing a little bit of a disservice if I didn't just talk about there is a broad continuum, an overarching vision for helping people access employment through the lifespan program that you see hinted at here by looking at the rates. There's a lot more variety here than there is in the existing programs, but I don't have the time to get into the details of what all of these services do. Wrapping up this summarization of the rates that we are recommending within the lifespan program. Again, you can read them on the screen or go to the rate model packet to get the detail for each individual service. So I wanted to front load those materials because I don't have anything further to say on any of those services. I hope that when you go to the rate model packet, given the explanation that you saw in the first half of this presentation, you'll know how to read it, how much we've built in for the wages. You already know what the benefits package looks like, how much we've built in for overhead costs. But there are some services where we thought more explanation was going to be necessary. And we're going to start with what we are grouping together as full-time residential services. The point that I want to make on this slide is that we are proposing a 350-day billing year for these services, which I know can feel counterintuitive and potentially punitive towards providers. However, this recommendation is intended to, and in fact is, entirely to the provider's benefit. So the way this works is we go through our typical rate setting approach, wages and benefits and productivity, et cetera, and we build out the cost of operating, say, a group home, and then we can expand that to the cost to operate the group home over the course of a year. Now, the obvious next step would be to divide by 365 days because that's the number of days in a year. But what happens if an individual misses a day during the year? Well, the provider's costs probably don't change because we're in a shared environment. They can't send home a portion of a direct support professional. So if I'm away from my home on a random Tuesday, the provider probably has the exact same staffing expense, but they're not going to be able to bill for that Tuesday for me because I'm not there. And so by dividing by something other than 365, we actually increase the rate. And what we're doing is dividing by 350, and that increases the rate by a little bit more than 4% compared to what it otherwise would be. So the long and short of this is that we are funding absences by assuming an abbreviated billing year because, again, for those short-term absences, providers' costs are unlikely to change. What that means is that a provider is fully paid for a year's worth of service after they've billed for 350 days. And you can go to the most extreme example. Let's say that we assume it takes $100,000 per person per year to operate a group home. The state could pay you $100,000 on January 1st, and pretty clearly they've paid you for a full year's worth of service. You can't expect to get $100,000 per day for 365 days. The same concept here, just less extreme. We're increasing the rate by a little bit to pay for those absences that might occur throughout the year. Now, if a person is never absent, this calculation doesn't matter. You get paid the exact same amount. But if they have more than one absence during the year, this 350-day billing policy is to providers' benefit because you don't start losing that $100,000 revenue until they dip below 350 days of attendance during the year. Again, this is what we proposed 5 or 6 years ago in the rate models for residential services in sections 18 and 20. So it's not a new concept, but something that we're recommending be expanded to the existing residential services in 21 and 29, as well as lifespan. I will also note that we recommend that billing limit reset if the individual changes provider during the year. Again, extreme examples help to illustrate my point. But if a provider cares for somebody for the first 350 days of the year, and then that individual transitions to a different provider, if that billing limit doesn't reset, the second provider can't bill for the first 15 days of service they're providing, which isn't fair. And so we would recommend that that billing limit reset if someone changes providers, not homes in the same provider, but changes provider agencies. Okay, so I know this is probably what many of you have been waiting to talk about, and so Paul already touched upon it at the top of the call. But agency home support, or group homes in section 21, is the single largest expense that the waiver is incurring. That's the majority of spending is on these services. And I know there's been a lot of challenges with staffing the homes, particularly post-pandemic. So one of the charges that we were given by ODES is to adopt a true, quote unquote, true per diem rate. And that is distinguished from today's per diem rates, which are actually a buildup of an assumed number of hours that get multiplied as identified in the section 3 of the main care benefits manual for section 21, chapter 3, I should say. And then providers have to deliver at least 92.5% of those funded hours. So although homes aren't typically funded for 100 hours per week, what happens is 100 hours gets approved, it's divided by the number of residents in the home, everyone has the same rate, and then providers must deliver historically 92.5% of those hours, or 92.5 hours in my example. If they don't hit that threshold, then they have to adjust the rate to account for what they actually provided. So it's built on a per diem basis, but it isn't a quote unquote true per diem rate because it really is tied back to specific hours. And if that hour threshold is not met, the rate gets adjusted downwards. So we are proposing the adoption of those true per diem rates, which are built on standard assumptions of appropriate staffing levels. So this would no longer be negotiated on a provider by provider basis like it is today. Instead, rates will vary based upon the size of the home and an individual's assessed needs, which means within a single home, you might be paid at different rates for different residents, because a home can have someone assigned a tier 2, tier 3, and tier 4. In that circumstance, that 3-bed home is billing a different rate for each of those 3 residents. Importantly, and what makes this a true per diem rate is, although the rate models are based upon assumed hours, which I'm going to show you here in a couple of slides, providers do not necessarily have to deliver that specific level of support or some percentage of that level of support. Instead, of course, providers need to deliver supports that are adequate to meet the needs of the individuals, certainly to ensure their health and safety, but more importantly, that are consistent with the individual's service plan to make sure that they're delivering on what the service plan is suggesting is supposed to be delivered within the residential environment. And that is meant to offer flexibility to providers. There will be the expectation that some weeks you might be delivering more than is assumed, other weeks you might be delivering less, but there will not be any sort of specific payment adjustments based upon those ups and downs and ebbs and flows. Furthermore, it's meant to accommodate different approaches to delivering services. So I know one of the controversies that's arisen over recent years is the treatment of overnight asleep staff. The rate model is silent on whether or not staff are awake or asleep during the overnight hours. Furthermore, providers can, if appropriate based upon individuals' plans, also use remote technology to cover or to complement on-site staffing. So maybe during overnight hours, remote supports are appropriate, or perhaps during the day, most residents are gone, but one person remains at the home and they can be served through a remote option. Again, it has to be documented, just like the overnight asleep staff, but if it's appropriate for the needs of the individuals within the home, those sorts of service delivery models, which again are meant to extend the workforce, would be permissible without having to reduce the rate. So I'm just pausing for a moment. I know we're not taking questions to the end, but to make sure that folks have a chance to read the slide, because this is a pretty impactful change to the single largest service that's covered within the existing programs. Okay, So in terms of how we developed the rate models, I already said the rates vary by home size. We have separate rates for homes with 2 residents, 3 residents, 4 or more residents. The home size would be based upon licensed capacity. The idea here is that on a per person basis, it's typically more expensive to operate a smaller home than a larger home because you have fewer people over whom you're spreading fixed expenses. So there's still more revenue at larger homes, but on a per person basis, the costs are typically higher in smaller homes. There are also a lot of placements that fall under the agency home support billing code that are a single individual. And so it's strange to say, but that's a one-person group home. In those circumstances, out of an abundance of caution of complying with federal requirements about not duplicating the same service hour through multiple services, the services the service delivery model for one-bed homes would not be reimbursed on a per diem basis at all, true per diem or not. It would be authorized and billed on a per hour basis based upon the actual supports delivered, just like home support quarter hour is. So when you look at the rate model packet, you'll see the true per diem rates for 2, 3, and 4 bed models, but for the quote unquote one-person group home, it's going to be an hourly rate. And then additionally, the rates vary based upon an individual's assessed needs and their resulting tier. So those 6 levels of need crosswalk to the 4 rate tiers. I already mentioned the point here at the bottom. Our rate models do not assume, do not desire, do not suggest, etc., that people ought to be segregated based upon level of need. When you look at the rate model assumptions, we build it out as if everybody in a home is all in tier 1 or all in tier 2. You have to do that because otherwise you'd have to come up with hundreds or thousands of different permutations of the possible combinations of residents. But that's not to suggest that we believe it's appropriate or desirable that folks be segregated based upon level of need. And so, as I said, you can have a home where there are people with a mix of needs, someone in tier 2, someone in tier 3, someone in tier 4. Absolutely nothing in our rate models, our rate study, anything else are meant to result in any sort of segregation based upon level of need. So I wanted to walk through one of the staffing examples. All of them are in the rate model packet, but here we have the staffing assumptions for a 3-bed home. And so unfortunately, I cut off the header, but the first column is for tier 1, followed by tier 2, etc. I'm just going to walk to the tier 4 model on the far right-hand side. We begin with the number of hours per week. 168 is 24/7. And then we divide that between daytime and overnight hours. Overnight, we assume 8 hours per night. So 8 times 7 is 56. Everything that's left is considered a daytime hour. And so now we have to make assumptions about how those periods are covered. And you'll see the number of FTE during the daytime hours, so first and second shift, and the overnight hours, the third shift. At tier 4, we're assuming that there are 2 staff on shift during the daytime hours and 1 staff on shift during the overnight hours. I'll come back to both of those in a moment, but that's the kind of baseline assumption that we are making for a 3-bed home. I want to note that in this model, we are not assuming that the home goes unstaffed for a period of time. Now that could happen, and I believe often happens, if people are out of the home during the same period of the day. You don't need to staff during that period. However, that also then kind of presumes that people will be doing the same thing during the day. In other words, going to the same day program, or at least the same day program hours of 9 to 3. That's not what Maine's trying to encourage in either the existing programs or in the lifespan program. So people should be able to participate in activities based upon their schedules and their desires. And so as a result, we didn't want to assume that the home goes unstaffed at the same time every single day. So you'll see that we're building this on the assumption that 24-hour staffing is covered. It's not a requirement. If people are out of the home, you don't have to staff those hours, but we did want to make sure that we're providing adequate funding to operate these homes 24 hours when appropriate. Next, you'll see in the scheme of things, modest adjustment called the shift overlap hours. This is feedback that we've gotten from providers over the years, including in Maine, about if we just schedule the shifts back to back, first shift, second shift, third shift, it's not providing time for debriefing across shifts. That makes a lot of sense to us. So now we include 15 minutes per shift to allow that debriefing to occur for the departing shift to tell the incoming shift what happened during the preceding 8 hours. And then we have floating staff hours, which is because I couldn't come up with a better adjective here. But this is meant to reflect the fact that there are other hours that might be necessary on an as-needed basis to complement the standard shift staffing up above. So you'll see, for example, at Tier 1, we're providing a half FTE of these quote floating staff hours, and at Tier 4, an additional FTE. So that could be used to supplement, or should be used to supplement what we are included in that 2-to-1 daytime staffing, or if necessary, for some additional staffing during overnight hours. But we added up at the home level. Here in the far right-hand column, we're at 350 hours. Divided by 3 for 3 residents, we're at 108 hours per individual per week. Again, if you had someone in Tier 2, 3, and 4 in this home, the number of funded hours would be 77.8, 95.1, and 108.4. Again, you don't have to manage these hours. It's a true per diem rate. But I just wanted to emphasize again the point that we're not suggesting that folks ought to be segregated based upon their level of need. So we don't do a lot of this, but we did want to provide a little bit of perspective about how those assumptions compare to what we've seen across the country. And the reason for that, to be entirely transparent, is because the staffing that we've observed in Maine is substantially more intensive than what we've seen just about anywhere else. And that's true even after you account for acuity. So in past conversations, the response has been, well, we're serving a higher needs population. And so what this table, or the tables on these 2 slides, show you is how the assumptions we've built in these proposed rate models compare to what we're seeing across the country. I'm not going to walk through all the details of this table, but if we look at the 3-person home, which is what I just walked through, we have 108 hours built in at Tier 4. So that's what I just covered, which is on the high side of what we've seen across the country. Georgia and Virginia around 100 hours. Oregon is actually, this is one of the few exceptions in the table, is higher. And then Rhode Island is quite a bit lower. Not meant to spend a lot of time on this slide, but what we wanted to demonstrate is we do believe that the staffing assumptions that we built in to the models are appropriate based upon what we see elsewhere for states that are using, for the most part, the exact same assessment instrument, the SIS, and are coming up with very comparable rate tiers. One of the other things that I would just emphasize, based upon the direction we got from ODES, is we did want to encourage 2-bed homes when appropriate based upon the needs of individuals. In other states, we don't have rate models for 2-bed homes. They have to build a 3-bed rate, which obviously is going to be quite a bit less than what we've built here in Maine. And that's a reflection of the desire to support those more family-like settings. And it's also just a reflection of the reality that there are a lot of 2-person placements in Maine presently. But the long and short of this all is, when you look at the numbers for the Maine proposals, in nearly every circumstance, what we've proposed is higher than what we have seen elsewhere across the country. And same table here for 4-person homes. So this shows you the rates. I will acknowledge that they are hard to compare to the rates that you're being paid today because it's an entirely different reimbursement model. So we pulled out the current rates from Chapter 3, and folks who do group homes know it's a little complicated. You have one rate for the first 168 hours, a reduced rate after that, and then a medical add-on rate when appropriate. Our proposed rates translate to $40 to $45 per staff hour. So they are higher on a per staff hour basis than what you're getting today. But that doesn't mean that revenue will necessarily increase. The impact of the proposed rates will vary based upon the tier that the residents have been assigned to and the number of hours that are currently approved. So I'll just backtrack on a couple of slides. If you have a home where everyone is approved for 1-to-1 staffing, 168 hours, pretty obviously, none of our rate models do that. So in that case, the revenue for that provider is going to decrease because we're not assuming one-to-one staffing even at tier 4. However, it's important for me to highlight the overall goal here is to provide flexibility, particularly on the staffing side, which is a point that Paul made at the top as well. So yes, the revenue might go down, but we're hoping that in a lot of cases, the costs are going to come down to a more significant degree, right? Because we're paying more per staff hour. And so if you provide the same number of staff hours, your revenue will increase. But if you're providing more staff hours or funded for more staff hours, your rate could go down, but it should be offset by a reduction on the cost side. Again, I can't provide a lot more detail because it is really going to be dependent upon each individual provider's current staffing levels, as well as the rate tiers that an individual will be assigned. That being said, a big part of the reason for these recommendations are the feedback that we got from the provider community, telling ODEs that they can't meet the 92.5% threshold and looking for relief. This is one way to provide relief, which is bringing down the staffing expectations and moving to this more flexible reimbursement model or a true per diem. For shared living, we've developed rate models for this existing service. The key assumption here as it relates to the rate tiers is how much we've built in for the payment to the home provider. Just like all the rate model assumptions, we're not suggesting this will be prescriptive, that agencies have to pay exactly these amounts. However, we are recommending that a floor be established and that providers be required to pay at least 65% of the total rate to their contracted homes. Again, that will be on the total rate. So these amounts are what's built in the rate model. You don't have to pay these. There's flexibility to negotiate a little bit less or a little bit more, but at least 65% of the total rate would have to be paid. Additionally, for shared living, we propose to eliminate the increased level of support rates because those are to fund additional staff hours. We think those additional staff hours ought to be unbundled and as appropriate, authorized and billed based upon what's actually being delivered. We continue rates for 1, 2, and 3 bed models, just like is in the existing sections 29 and 21 at least. And then the rate models, although not detailed here, it is in the rate model pack, include assumptions for agency expenses like recruitment, oversight, supporting, and training home providers. This just shows you the rates themselves, which I will not read to you. The footnotes are important though. The rates won't tie exactly to what you'll see on the fee schedule because we've converted it for a 350-day equivalent. We didn't want to hide the ball here. So you'll see what you would be billing if 350 was currently in place versus what we have proposed. You'll see that there is at tier 1 for one member a rate reduction, but otherwise the rates go up for shared living and in a lot of cases are going up pretty substantially. I'm going to need to spend a couple of minutes as I'm trying to get through the handful of slides I have left on community supported living. So this is a new service that would be unique to the Lifespan program. It's meant to support an individual or maybe a couple of individuals in a community residence of their choosing. And it's meant to pay providers for staffing that could occur both on an as planned and as needed basis. So again, that's a high level description. There'll be more in the service definitions themselves, which I'm not getting into during today's presentation. But in terms of how the payment model is going to work, we propose a monthly payment rate. And the rate primarily varies based upon how many staff hours we are assuming. The rates will be tiered. And we are assuming that at tier 1, the typical service level will be 15 hours per person per week. At tier 4, 25 hours per person per week. The rate model, though, includes more than just direct supports. It includes coordination work. The agency's meant to provide, I wouldn't call it a whole life model exactly, but elements of that. So maybe helping with scheduling, transportation, and the like. It is meant to, the agency has to be available 24 hours, not on site, but has to have on-call availability at least 24 hours per day. And then it also incorporates bundled professional supports like nursing and behavioral support consultation built into it. So in terms of how the billing would work with this monthly rate, providers can bill the full monthly rate if they deliver at least 80% of the hours assumed in the rate model. That's for in-person hours only. And that's intended to account for the variability in service needs. So some months might require more supports than what gets built in the rate, and other months might require less support. So it's not a guaranteed revenue. You actually have to deliver some threshold of support in order to bill that full monthly rate. So I'm going to make the numbers round. 15 hours per week is about 60 hours per month. 80% of 60 is 48 hours. So as long as a provider delivers at least 48 hours, they're able to bill the full monthly rate. If not, the rate gets bifurcated. We continue to have a rate that covers the oversight and coordination costs, so the on-call response, the coordination, the professional supports, because we treat those as fixed expenses, and we don't want to shortchange providers. So the direct support gets pulled out. Providers still get paid the full rate for the oversight and coordination. And then they bill the direct support rate for the number of hours that they actually delivered. So if they delivered 45 hours at tier 1, they would be billing the unbundled rate, which is the coordination rate of $2,300, plus 45 hours at this $11.05 rate. Hopefully clear. For remote monitoring, another shift that we're recommending is to change how the remote monitoring function and the remote interactive support gets reimbursed. So currently those are both reimbursed per hour. What's being proposed is eliminating the hourly reimbursement and moving to a block billing of $250 increments. So we're proposing a rate that's just $250 per unit, and up to 6 hours per month can be authorized. So up to $1,500 per month can be authorized based upon the needs of the individual. So that would be determined on a person-by-person basis how many of those $250 per hour blocks would be approved for the individual. Once approved, that's what the provider would bill for each month. If there is a need for an in-person response and providers continue to need to have the ability to provide for directly or indirectly those in-person responses, that would be billed on a 15-minute basis. But the oversight function, as well as the interactive support function, would all be built into that 250 per unit, 250 per unit block rate, up to $1,500 per month. So there would be no other billing for the remote activities, whether that's monitoring or interactive supports. It would not be available in a provider-controlled setting like a group home. I said already, though, that the per diem rates are meant to facilitate that type of innovation. So providers can use a portion of their per diem rate to contract on their own with a remote support provider, or use it to pay their own staff if they have remote monitoring functionality. But it wouldn't be separately billable for folks who are also receiving group home or shared living type services. And then the last service I wanted to hustle through in my last few minutes here is day program, which has a variety of terms today: community membership group, and community support, and then in the lifespan facility-based day program. So importantly, the rates vary by location of service. We have rates for community-based supports and rates for center-based supports. The community rates are higher to accommodate smaller, more intensive staffing, smaller group sizes, more intensive staffing, I should say, as well as to accommodate mileage-related expenses. Importantly, if an individual receives both facility-based and community-based services on the same day, the provider will be billing both of those rates. So if I'm attending 9 to 3 and I'm in the facility from 9 to 1, that's 4 hours or 16 units. 16 units gets billed at the facility-based rate. If I'm then in the community from 1 to 3, 8, that's 2 hours or 8 units, and 8 units gets billed at the community-based rate. We want to make sure that we're supporting hybrid programs that have both a center-based and community-based component. but rewarding those providers that are spending more time in the community. It's not meant as a punishment for those who have a facility-based program, but the more time that providers are delivering community-based supports, the more revenue that they're going to receive. Additionally, the rates vary based upon assessed needs. And the reason for that is we're assuming more intensive staffing for individuals with more significant needs. So this is also what Paul was making reference to at the top in his remarks. We have proposed to reduce the staffing requirements from at least historic practices. So for facility-based services, what we're proposing is going from somewhere between 1 to 6 to 1 to 3 compared to the current 1 to 3 expectation. So at tier 1, the rate model funds a 1 to 6 ratio. At tier 4, it funds a 1 to 3 ratio. Providers always have to deliver whatever the minimum funded ratio is, which is 1 to 6. So it doesn't matter who's in their group, they have to deliver at least 1 to 6 staffing. Again, that's meant to provide flexibility to providers, because unless you have a group that only has people in tier 1, which is pretty unlikely, you're going to have, most groups are going to have a mix of individuals. You're always going to be funded for more staffing than what you're required to deliver, right? Because you're going to be funded some weighted average of 1 to 6 through 1 to 3, but your expectation is always going to be 1 to 6. Currently, on the community-based rates, the current rate assumes 1 to 2. We're proposing 1 to 4 at tier 1, 1 to 3 at tier 2, and 1 to 2 for tiers 3 and 4. And the minimum required ratio, I should actually say 1 to 4 here. So I'll make sure I change that before we post this. But the expectation would be that you're delivering services at a 1 to 4 ratio, regardless of the actual composition of the group in which you're working. Now, we don't want providers to always go to the lowest allowable ratio, but the goal here is to provide flexibility, to recognize that there are fluctuations that occur hour to hour, day to day, week to week. And as Paul said, give relief to providers given the workforce challenges that everyone has been experiencing for quite a few years now. I'd also be remiss if I didn't add that there still remains a 1-to-1 community-based rate in all of these programs. So I covered that without noting it in the tables at the top of the slide. There is that community support 1-to-1 or community membership rates. That's not going away, but these are for shared services within the sections 21, 29, and lifespan programs. This just shows you the rates, which I'm not going to read to you, but I don't want to gloss over this because the rates themselves are being reduced. The reason for that is because the staffing expectations are being reduced. We're going from a 1 to 3 assumption to in some cases 1 to 6. And so as the staffing expectations go down, because that's the single largest expense, the reimbursement rate also declines. So next steps, and then I know we've left only a few minutes for questions, but as we've said, the rate models as well as this presentation are going to be available online here once we have the recording ready to go. We're asking providers to submit comments in writing over the next 2 weeks. I explained that we're going to review them and provide a written document that provides a summary of what was received as well as the actions taken or not taken in response to all of those comments. I just want to note, we encourage you to be as detailed as possible in your feedback. If you say that you don't like the rates, we'll accept that, but it's really, really unlikely to result in us changing our recommendations. Instead, what we're looking for is, we don't like the rate because we think you made this mistake or you ought to make this adjustment. And then we will evaluate what specific recommendations you have offered and make a determination about whether or not an adjustment is made or not. So please be detailed. If you have any supporting documentation you want us to consider, that would be helpful as well. We want these rates obviously to work for the providers, but more importantly, the people that you serve. But we can't do that unless we really understand what specific concerns or issues that you have when you're providing that feedback to us. So I have contact information here, but we also have a dedicated email account set up so that nothing gets lost. We ask that you submit those comments to us by April 29th to this odesratestudy@healthmanagement.com. With that, I think, Jessica, am I turning this back over to you for the
Yes.
handful of questions that we have time for?
Yes, so I do have some questions in the chat, but because I have them, I'd like to see if people would like to take this opportunity to raise their hand, because we can always take those questions back because they have them in writing if we don't have time. If you could raise your hand, try to keep it limited to a couple of minutes for your questions. If you're on the phone, you can participate by selecting *9, and we'll take the questions in order that they're coming in. And I'll call you by the name that's on the screen, and I'll ask you to unmute yourself. So I'm seeing Kristen has a question. You should see something that says to unmute.
Thank you so much. When you were talking about the community-based and facility-based rates, one of the questions that I have along those lines is, will you be requiring, or will there be separate service authorizations for those locations, or would it be one authorization and instead we would be providing supporting location documentation for billing backup? That's one of two questions I have.
I defer to the OATS team. That is a question that we've addressed. It's going to come down, we may not have an answer because it's going to come down to the functionality of the MMIS in terms of whether or not multiple rates can count against the same authorization. So it would be ideal if that's the case, but we're going to have to make sure that the systems allow us to do that.
Okay.
And I just wanted to follow that up with to remember that any official comment should come to us in writing to the mailbox that we've posted.
Excellent. And then my second question was just on slide 57. I saw it said the group home, it just said proposed rates, and were those per person per day, or were those per day per home?
It's a good question. Per person per day.
Okay, thank you.
Heidi?
Hi, I'm Heidi Manser. My question relates to the one-person placement in group homes that you spoke of. You talked that it would be an hourly rate for a single person placement. Can you tell me whether remote supports or other would be allowed in a one-person placement? Is that part of the decision making?
Send us that question, Heidi. I mean, I think in general, we're not ruling out remote support for anything. That said, as you know, single person placement is not a normal thing in our system. It's an exception. So it would be hard to imagine a person whose needs were at that level who could also be supported remotely, but send us the question.
Okay, thank you.
Thank you. Pete, go ahead.
Thank you. This is kind of a cover could have been asked in both the other questions. There's a lot of changes to Chapter 2, I would imagine, that are coming to reflect all of these changes, and a couple examples we just heard. I'm sure there's many more. Is there a timeline for Chapter 2 that ties to the timeline of Chapter 3 for the rates, so that they'll be kind of happening simultaneously?
I'm going to defer to Tom or Heather on this, but I think we want, when we get to the point of rules, we want them all to be done at the same time.
I would like that. That would be good. That would be good.
But I don't know, Heather or Tom, if it's different than that, please jump in.
Oh, let me unmute Tom. Heather or Tom, would you be able to answer? If you can raise your hand, I can unmute you. I'm not sure who's still on the call or not. That's fine.
That's okay. You can send it in also, Pete. Why don't we just keep moving since we only have a few minutes?
Yeah, a couple of minutes. Yep. Andrew?
Good afternoon. Increased shared living was bundled because you couldn't bill a quarter hour and a per day home support on the same day. So is that something that is changing? So intermittent home supports and shared living were put together to create that bundled rate. And so if you take them apart, you have a home support, intermittent home support, and shared living, which is services in a home. And that's a per diem and a quarter hour. So is that rule going to change?
That's the proposal.
Okay. Thank you.
You should be able to unmute yourself.
Perfect. Thanks, Jess. And this is just the question Paul referenced earlier. From the main care perspective, we always want to time the chapter 2 and the chapter 3 rulemakings together. Section 21 is unique that one is obviously major sub and one is routine technical. So that gets a little tricky. But we will try our best to get them timed up and synced, proposed and adopted in as sort of timely and close enough time as we can.
Thank you, Tom. Amanda, we're going to try to get through Amanda and Fawn if we can.
Hi, I have 2 questions about the behavior consult. I understand from the NDI Teams channel that the LCPC will be allowed, and I wondered what the rate would be for that person, and also are the number of behavior consult hours going to be increased?
I'm going to channel Paul on that one. I don't have off the cuff responses to either one, so if you would submit those in writing, we'll take that as part of the overall public comment process.
Thank you. Last question, we'll take on, and then the ones that are in the chat, I will for sure get them to the right people. But please follow up in writing to the email to ask official questions. And you should be able to unmute.
Okay. Yeah, my question is for the community supports, where it's proposing, staffing ratio by tier, where tier 1, tier 2, you can have, 1 to 6, 1 to 5. Does the rate accommodate all that documentation time? Because you're looking at, at least if a person's really good at documenting, 15 minutes per person, and that's like 90 minutes documentation time on that ratio. So is the rate looking at all that time?
I will say that there is a assumption in there for record keeping time. It is higher at the lower tiers because you're doing documentation for more individuals. It's not certainly as high as what you just suggested. But if you look at the rate model, you'll see how much time is built in on a per week basis. And we're open to feedback on that and all the other assumptions that we've included.
Yeah, thank you. Because with HCBS, it's longer documentation time than it used to be. And someone's gonna have to be really good to do one in 15 minutes and not, we're talking sometimes like 20 or 30 per person, depending on what they've done. So I just wanted to check on that.
Thank you all very much. This is, we look forward to your comments and continuing the process. Thanks, everybody.
Thank you.